Hello, my name is Catherine. I'm here on behalf of the Student Doctor Network, and we're going to be interviewing Dr. Sean Rogers, which is a third-year family medicine resident. And so could you please tell us a little bit about yourself, Dr. Rogers?
Yeah, absolutely. Thank you, Catherine. So, like you said, my name's Dr. Sean Rogers. I am a graduating third-year family medicine resident coming from Womack Army Medical Center's family medicine residency at Fort Bragg, North Carolina. So, a little bit about myself. I graduated from medical school in 2022. I graduated from undergraduate at University of Northern Iowa back in 2017. And then before that, I worked as an emergency room nurse. And before that, I also worked as a nurse within the Army. And I was a medic in the Army and enlisted back in 2008. So it's been a little bit of a trek.
And when did you first decide to become a physician and why, especially coming from a nurse background?
Yeah. So I first decided to become a physician when I was working in the ER. I had thought about all of the different courses I could take to kind of become an advanced practice person of some sort. And originally had thought about becoming a nurse practitioner or a lot of other avenues. And after working in the ER and seeing that there was a pretty significant knowledge differential, and in terms of the ability to do different tasks, do different procedures, and just the amount of respect that you were given, I decided to go down the road of becoming a physician instead. And so I kept working in the ER while I did my undergraduate and then got accepted into medical school.
How and why did you choose the medical school that you attended?
That's a great question. So I wanted to go to an osteopathic school from the get-go. I only applied to a couple of MD schools up front. And the reason for it was, having been in the ER, I had seen quite a few patients come in with back pain, upper back pain, thoracic pain, and I had seen several of our DO-trained ER physicians be able to do OMT for those patients and completely resolve their symptoms without the use of any medication at all. And the risk of doing those OMT procedures was very low. And the benefit or reward from it was those patients weren't going home with different kinds of medications. And at this point in time, it was still very much during the opioid epidemic. So I was seeing a lot of patients go home with Norcos or Percocets for simple things like thoracic back pain. And they would get 10 Norcos to go home with. And then I saw other patients have one treatment over the course of 5 minutes and walk away happy. And that really influenced which school I chose. The final decision came down to one school was close to home, the other one wasn't. So I picked the one close to home.
And what surprised you the most about medical school?
Oh man. So one of the things that surprised me the most about medical school was the pure volume of information during those first 2 years. I had been used to high volumes of information through a lot of different schools that I had gone through, but nothing compared to the volume in those first 2 years of medical school. You're essentially taking 24 credits of graduate level courses, and you're expected to do the same, if not better, than you would in undergraduate courses. And in most graduate schools, you're taking 8 credits and expected to do the same quality of work. So that volume was huge, and it was a lot to figure out, especially in the beginning.
Did you say you were a little bit more prepared because you had that nursing background, or was it still a lot of a challenge to get used to the workload and it was very different?
Yeah, I actually struggled a lot in my first 2 years of medical school because a couple of different reasons. My background as a nurse gave me the ability to have that practical experience. So I'd seen a lot, but understanding the underlying pathology or the underlying physiology wasn't necessarily something I knew quite as well. And on top of that, I had gone through nursing school and undergraduate and everything else. And I was one of those people that didn't have to study very much. So when I showed up to medical school, they start you off with one or two easy classes and you're doing pretty okay. And then they throw biochemistry and anatomy and physiology and everything else all at you all at once. And it is just absolutely overwhelming. And so I had to completely relearn how to study and relearn what my method of studying was in order to be successful. I didn't graduate as the top of my class, but I didn't graduate as the bottom. And at the end of the day, I was able to be successful and have gone on to be successful throughout all of residency.
Congratulations. And how did you choose your specialty?
Yeah. When I showed up at medical school, if you talk to any of the people that sat right next to me on the first day, they would probably attest that the very first thing I said was, I'm going to be an ER doctor. And the one specialty you will never see me in is family medicine, because I don't want to be in a clinic all day. And then I started doing my clerkships in my third and my fourth year. And I ended up in a couple of different rural hospitals in rural Iowa. And in those locations, you would have, one or two or three family medicine docs, and they would do everything. And you would have these small county hospitals that you would see clinic, 3-4 days a week. And one of the docs would cover an inpatient service that had anywhere from 4 to 10 patients. And on weekends, they may cover the ER as well. And it would be a small critical access hospital. And for me, that was so great to be able to see that broad array of skills being utilized. And on any given day, you might see a couple of kiddos for well child checks. You might see, an adult for any random complaint. And then, of course, the dreaded farmer that came out of his field for a doctor's appointment, something bad is happening. And then all of the things that came in between. And I was just completely taken aback by how much variety there was. And I was somebody through most of my third year who I couldn't choose a specialty to save my life. I enjoyed everything. I thought everything was interesting, and I could see myself wanting to learn more about it. And then I got to do everything with family medicine, to include peds and obstetrics.
And what other specialties did you consider, and why did you go with family medicine at the end?
So cardiology almost pulled me away. I completely fell in love with cardiology during that rotation. And so I thought very hard about going into internal medicine for that reason. But at the end of the day, I knew I wouldn't be happy being pigeonholed into one small area, and I would want to branch out. I would want to know more about all the different areas. And I enjoy inpatient medicine, but I actually really, turns out I love working in the clinic. I love seeing patients, building that rapport, and being able to see the changes over time. The patients that I've had for 3 years now, who I've developed those relationships with, and we've made progress, and we've seen huge changes, and it's almost like they're family. And so now getting ready to leave, it's hard. It's very hard.
Would you say that bond with your patients was something that really changed your decision from, let's say, emergency medicine to family medicine as well?
Oh, absolutely. The thing that I found with emergency medicine is that it's exactly in the name. You're dealing with emergencies, or what people perceive to be emergencies. And the perception of an emergency is no different from one person to another. It's just that scale of what you as the provider also perceive. And a lot of those things that they came into the emergency room with were things that were preventable. They were things that could have easily been solved. Your patient who's coming in with a hypertensive emergency and a headache and vision changes and their blood pressure is 240 over 140, that could have been solved so long ago with the simple addition of 1 or 2 medications or some lifestyle interventions or a combination thereof. And somebody taking a little bit of time or multiple appointments to go through that with them, you can solve a lot of problems up front with a little bit of work on the back end.
And what is unique about serving as a physician in the Army?
So we get to serve, or we get to help take care of a very unique population. Fortunately, in our area, we have a huge retiree population. So my clinic is composed of a huge variety. Probably 50% of my patients are over the age of 50. And then 40% or so, maybe 30%, are somewhere between the ages of 18 and 30. And then the majority of the rest fall outside of those ranges. So, quite a few peds, and then some of those a little bit older, but not quite into the geriatric range. But one of the additional challenges that we have is throughout all of our training, we're not only learning how to take care of people in a clinical setting or in a clinic setting, we're also considering, how do we take care of people in austere environments? How am I going to deal with somebody that has a medical condition that I'm needing to evaluate without the utilization of labs? I don't have access to X-ray. I don't have access to a CT scanner. I have nothing more than the tools that I have in essentially a couple of totes. And then how am I going to be dispositioning those patients? And the consideration also sometimes has to be made of, how can I also further whatever engagement we're a part of? So how do I optimize medical resources to ensure that I'm helping the most people in as short of a time as possible, while still providing good care and allowing our forces to progress forward in a fight? And it's learning about all those differences. There's also a higher concentration on trauma because of the environments that we can find ourselves in. So in our intern year here, we go through a course that gets us ATLS certified. We spend some additional time in a couple of local trauma centers to get some additional training. And we get some additional training on the back end for skills that some family physicians may not commonly be trained in.
And would you say your experience as a nurse in the ER helped prepare you for these more trauma-oriented experiences?
Oh, absolutely. Yeah. I had the opportunity to see a lot of different pathologies there. It also helped to better prepare me for the last 2 years of medical school. I had experience working with patients and talking with patients, taking histories, and I was very comfortable around patients, and sometimes in difficult situations, sometimes my peers weren't as comfortable with. And so both in terms of preparation for some of those more trauma-oriented events, as well as just preparation for the last half of medical school and what I would probably argue were some of the most important years of medical school.
Yeah.
I think that nursing as a whole provided so much benefit that it can't really be determined how much it is.
Yeah. If you had to do it all over again, would you still choose the career path? Why or why not?
I've thought about this question a lot, especially going through residency. Would I want to do this? And I would still do the same thing. And I would probably take the exact same path that I did to get here. It wasn't the fastest, it wasn't the easiest, but every experience along the way has helped to shape me to become the physician that I am today. And I truly believe that I would be a worse physician had I not had those experiences.
And has being a physician met your expectations?
Yes, for the most part. It's just like your mood, right? So you're going to oscillate. Some days are going to be great. Some days are going to be terrible. And you're going to walk out of your, 10 patient panel for the morning, and you're going to be running an hour behind because everything just fell apart and people didn't get screened on time. People showed up late and everything just went horribly wrong. And you're going to sit down to now write the 10 notes that you didn't have time to write in your clinic and wonder, why did I do this? Why have I done this to myself? And there are other days where you catch something or you help somebody, even if it's nothing huge. It doesn't have to be necessarily, oh, I caught this one in a million case, but it's important to somebody. And being able to help someone and see that you created an actual change or a benefit or something to help them is so rewarding that's everything I wanted.
And what do you like most about being a physician, and what do you like least?
I think I kind of answered just a minute ago. I love helping our people, and it's very stereotypical, right? When you're going in for that medical school interview, they ask you, why do you want to become a physician? And you say, I want to help people. It hasn't changed, right? I still want to help people. I love being able to take care of our soldiers. I love being able to take care of our dependents, their kids. I love taking care of our retirees and hearing all of their stories. And that is what brings me a lot of joy and what I come home with and making me feel fulfilled. What do I like the least? There are a lot of non-medical hurdles that go into medicine. For military medicine, we're fortunate in that we don't have quite as many of those hurdles a lot of times. I'm not fighting with insurance companies to say this person really needs this test. I'm not fighting with insurance companies to argue about very much at all. The worst thing I have to do is submit a prior authorization for a medication most of the times. But oftentimes that can lead to delays in care because the entire system is inundated. And so having a patient come in with a problem and you know what needs to be done, and so you order those things, you try to get the ball rolling, and they come back for that follow-up 4 or 6 weeks later, like, hey, so how did everything go? I haven't seen any documentation. They go, yeah, I just got scheduled for that test and I'll get it done in like a month. Oh, okay, great. And that's not just a problem of military medicine in the area where I live now. It's just a problem of there are not enough medical resources to go around. There aren't enough physicians. There aren't enough nurses. There aren't enough radiology technicians, lab techs everywhere along the way. There just aren't enough of them.
And would you say, when you said you liked being most about a physician is helping people, how would you say your ability to help people changes when you were a nurse to now that you're a physician? Do you feel a very big difference in your ability to help people in the way that you initially wanted or saw yourself in the future?
So yes and no. In the ER as a nurse, you're very hands-on. You are spending a lot of time with those patients. You are talking with them. You're at the bedside it feels like almost constantly. And that is what I loved about working as a nurse in the ER. And that's what I hated about my time as a medical student in the ER, is that I didn't feel like I got those relationships, those connections that I did. And now in family medicine, I do feel like I have those connections. And I feel like I am being fulfilled in a very similar way. It's just the biggest difference is as a nurse, you are doing the things that somebody else has requested you to do. You can provide some recommendations at times. You can ask questions along the way. But at the end of the day, you're doing the orders that a physician or a provider put in. Now, it's me who's making the decisions, but I still get to be hands-on. I still get to talk with my patients. So I hope that answered your question.
Yes, thank you. And what does a typical day look like for you?
So I'll answer that in 2 different ways because it depends on if you're on an inpatient or an outpatient service. So right now, a typical day for me looks like, waking up, trying to carve out some time to work out, go for a run, try to stay active however I can. And I'll typically try to get to work between 6:30 and 7 a.m. Try to finish up any notes or anything like that I might have left from the day before. We have a huddle that starts at around 7:30 and our panel starts at 7:40. And at 7:40, you start seeing patients. My empanelment is that I have 20-minute appointments, and I see 10 patients in the morning, 10 patients in the afternoon. So my day typically gets done. I stop seeing patients around 4:30, depending on how everything is going. And then I typically take, if I was able to get a lot of my notes done, I can leave pretty soon after that. If I wasn't, then I normally stick around to try to get as many notes done as I can. Some days I'm going home at 5 o'clock. There are other days where I'm going home at 8. For the majority of the last year, I was also one of our chief residents. And so a lot of it also revolved around trying to settle interpersonal problems within the residency. Sometimes people can't take a call shift, or their life happens and things come up. And so you're trying to solve those problems and trying to foresee problems and head them off before they become a real issue.
Yeah.
On the inpatient service, it's similar, except the day starts a lot sooner and goes a lot longer. So, we typically get in between 5 and 5:30 and show up pre-round, sign out, and then rounding normally by 9 o'clock. Then after that, it's solving all the problems of the day, which sometimes there are a lot and sometimes there are a few. Our inpatient census typically sits somewhere between 10 and 20 patients of all sorts of pathologies. And then we sign out at about 6 p.m. and we stick around until all of our work is done. So sometimes that means we're walking out the door at 6. Other times we're hanging out until 9. So it just depends.
How much of your work is research and or teaching, and do you like the amount of each that you currently participate in? If not, why?
Yeah. At this exact moment, it is maybe 5% research, and I probably have a medical student with me in my clinic 1 out of every 3 to 4 clinics. Sometimes as much as 1 in every 2. We have a lot of students that rotate through from the Uniformed Services University. We also have a lot of medical students that are coming in for audition rotations from all sorts of medical schools around the nation. And we also have PA students that rotate with us as well from the Uniformed Services University. So a lot of learners in our clinic. Our residency in particular has a lot of research opportunities if you want to take them. There's a research requirement, but you can take that as far as you want. And so I found out that I enjoyed doing research and incorporated that into a lot of my time during residency. I spent a lot of my free time working on it. Fortunately for us, we have a huge data set involved with the military. And so I was fortunate enough to do some research with hypertension and young individuals. And this is one of the only places where you have the opportunity to have a sample size of 23 million encounters without going too far. And so, yeah, I like the amount that we're able to do research. It kind of is what you make of it. So you can do the required amount. It's not a ton, or you can keep on going. And it's just how much work you want to put in. And for teaching students, I really enjoy teaching. I like being able to talk people through things. You have the residents and the staff who will sit down with you and talk through things with you. You have the other ones who pretend that you don't exist. And so you're trying to learn through inferring. And I always strive to be the former and not the latter.
Thank you for
and
that.
I enjoy that process.
On average, how many hours a week do you work? How many hours do you sleep per night? And how many weeks of vacation do you take?
Oof, that's a variable. On a good week, I work 50 to 55 hours. On a bad week, now remember, so ACGME requires that your work hours are averaged across 4 weeks. So that means that you can work more than 80 hours in a week. As long as averaged across 4 weeks, you only work 80 across those 4 weeks, if that makes sense.
Okay. Yeah.
And so there are weeks that I've worked over 100 hours, and those are long
Wow.
weeks. Those
Wow.
are tough. But then you balance that with, okay, you work 2 weeks that are 100 hours and 90 hours each, and then you work a couple of weeks that are 45, 50 hours.
Okay.
And it averages out to that 80. And it balances out in the end. For how many hours I sleep, now I sleep great. I get like 8 hours of sleep a night. But there were definitely times where it was, some nights you don't sleep at all because you have a 24-hour shift. You're in clinic all day, and then you pull a night call and you're in the hospital for 24 hours. And on those days, you might not sleep at all. On average, probably somewhere between 5 and 7 hours for the majority of residency. And our residency, we have 4 weeks of leave that we are allotted as long as they're taken during leave eligible rotations. And one of those weeks is reserved as sick time. So in case we get sick or anything like that, we don't have any problems. And we're also very fortunate in that we can take sometime during our second or third year, distribute across those. If you have a kid or anything like that in residency, you can take an additional 4 weeks without having to extend necessarily, which is, such a great opportunity to be able to spend time with our families.
Yes, 100%. Are you satisfied with your income?
Yes. Fortunately, in the military, we actually make significantly more than most residents in the civilian world do. So I was a part of something called the Health Professional Scholarship Program, which is a scholarship program through the military, through either the Army, Navy, or Air Force. You can do any of the 3 of the branches. And in that, they pay for 100% of your medical school. And they provide you with a stipend every month that you're in school in order to live off of. It's a constant stipend regardless of what geographical location you're in. So if you're in Washington, D.C., it doesn't go very far. But if you're in Iowa, like I was, it went pretty far.
Okay.
And then following that, you do your military residency, and your pay is determined off of your rank and how much time you've had in service, which is something you can look up online. It's freely available public information. And so compared to, a lot of my friends who are in civilian residencies, I probably make double what they do right now. And it balances out in the end, because when I'm done with residency, I probably won't make quite as much as they do. The military tries its best to balance out the income that you get after you're done with your residency training against your civilian colleagues. It can only go so far, but they try really hard to get as close as they can.
Oh, that's good. What information or advice do you wish you had known when you were a pre-med student?
Oh, man. That was a while ago. So I think what I would have appreciated was, the process of applying to medical school is not intuitive at all. And there's nobody out there who walks you through the process. Most people, they're undergraduate advisors. They're like, yeah, medical school exists and you're going to have to take these classes to get there. And they're like, cool, what do I do then? And they're like, I don't know. Okay. Then you're like Googling things. You're going to places like Student Doctor Network. You're going to Reddit. You're just panicking and looking everywhere, trying to figure out what your deadlines are. What do you need? What exactly do you need? What makes me a really good applicant? And you're just doing your best. And hopefully you've got a mentor somewhere along the way, maybe somebody who's been through the process who can help you out with that and say, hey, calm down. It's okay. It's going to be fine. Go start talking with some of your professors and things, do these, get some letters of recommendation, do all these tasks, and then come back, sit down, breathe, and then start working on your applications. And I wish that there were more guides out there on how to prepare yourself for the actual application process. And I wish I would have known how much it costs to apply to medical school.
Yeah.
Because it is not cheap. There are scholarships, there are reimbursements out there for those who are low income, but for those who are just above that low income mark or on their own or anything like that, it's, carve out a good like $800 to $1,000 just to apply. And then, I applied in the time before COVID. And so all of my interviews were in person. And so then you're driving or you're taking a plane ticket, you're trying to take time off for class to fly out someplace, do an interview, fly right back. And so each interview was a $500 adventure.
Wow.
And so that I wish I also would have known what the financial burden was just of applying to medical school.
Would you say being a non-traditional pre-med student made it more difficult, or was it slightly easier because you had experience, at least with some doctors that could walk you through it?
Oh, no. The doctors who I knew had been through the process like forever ago. They had no idea. I'd be like, what do I do? And they're like, I don't know. There were scribes at my hospital and they were also pre-med and they were just as clueless as I was. And so we were all just lost together. We were all just completely lost together. As for being a non-traditional student, it was good and bad. When you're like 28 sitting in classes with 18-year-olds, sometimes you just kind of sigh and shake your head a little bit and go on with your life. But it was good. It was good.
It was worth it. It was worth it.
Yeah.
And from your perspective, what is the biggest problem in healthcare today?
Man, loaded question. I think that most providers from any specialty doing anything would just about agree that the problem is multifaceted and it's a wicked problem. If you tried to say that there was just this one thing in healthcare and if we did this one thing and it would all be fixed, you're wrong, because there are so many problems that you have to fix all of them concurrently or make small strides in order to make any change whatsoever. Access to care is terrible. Try to going into a low income area and finding a primary care doctor that takes Medicaid. You're waiting months to get one healthcare appointment in those places. And that's assuming they have availability on their panel. And so you're shopping around just trying to find something. And then on top of that, the cost of care is horrendous. If you are not well insured and making plenty of money or have an employer that is able to help you out along the way with good health insurance, then you're being footed with bills that are just completely ridiculous. And it's made even worse through the difficulties that most people have, or most even providers have, with insurance companies, and insurance companies dictating what we can and cannot do that they will pay for. And so medicine oftentimes is less of a thing of what is the best practice, and instead, what is the best practice that my patient can afford? And that is heartbreaking. Again, we're fortunate in the military that we have access to tons of great medicines. If I have a patient that needs empagliflozin or Jardiance, I don't have to worry about the cost of it. If I'm in the civilian side and somebody needs empagliflozin, that might be a $2 a day pill. And that gets expensive really fast.
Yeah.
And that's not including, the Entresto that they also need, and the metoprolol and the metformin and everything else. It's not hard for those costs to balloon when you've got a couple of medical conditions. So it's a long answer, but it's multifaceted, and there are a lot of problems with healthcare today. We're doing the best that we can to try to mitigate it for our patients.
Thank you. And where do you see medicine in 10 years?
If it's continuing to go the way that it is right now, in trouble. The population is growing, and the number of healthcare providers, specifically physicians, that we are producing is not at the same rate as what we have a need for. And my concern is that the push to produce physicians is going to be so strong that we will end up giving up a little bit in the way of the quality of physicians we are generating. And that concerns me. I'm concerned about programs that are shortening the length of medical school, and shortening the amount of time that students are spending both with practical learning and at the bedside. That experience is invaluable. And through reducing the time that we're spending, you're not doing anything but reducing the experience that people have going out. I think that it can be turned around. I think that we can absolutely do things to help. But again, there are a lot of small changes that need to be made. And the access to good education has to be improved, both for those of good means and those who are struggling. And the barriers to healthcare need to be looked at in terms of how much is being dictated by insurance companies, or in terms of even what available resources are. There are tons of problems that we can look at, but if we keep going the way we are, I think we're going to be in trouble.
Yeah, I agree. What types of outreach or volunteer work do you do, if any?
Well, we have a free clinic in the Fayetteville, North Carolina area called Care Clinic that provides free care to those who are in need. And so as part of a program, we're required to help in that clinic occasionally. But even when I was a nurse, I worked in a free clinic. And so I've tried to be there as often as I can. And then in addition, I have tried to stay in close contact with my medical school and my undergraduate school to try to help out any of the medical students and pre-med students who want help along the way. Just like what we talked about, there's not a guide out there that says this is exactly how you do it. And the only way that we generate change to make this process more transparent and make it more approachable for more people is for people turning around and looking behind them and saying, how can I help those who come after me? Instead of putting up roadblocks that prevent people from coming behind them and make that process harder. It's a double-edged sword, but I think that's something we can all do. And I think it's important that we all turn around sometimes and try to help out at least one or two people that are coming after us.
Thank you for that. I know how much value that has. And how do you spend your free time, and what hobbies do you have?
Oh, man. Well, I just got reintroduced to free time. It's pretty great. For me, I love doing woodworking. I love working with my hands. And so I do woodworking on the side. My wife and I also love playing board games. So we'll go to a coffee shop or stay at the house or do whatever, and we'll play board games or have people over. We're very fortunate that in my residency, a lot of us are nerds. And so we bonded over board games. It was pretty great.
That's nice to hear. What qualities have led you to be successful in your current role?
Adaptability. So no matter what you do or where you go, the environment that you're going to will change. And if you are rigid, then you will have difficulty in moving forward to the next step. But being adaptable, being flexible always helps with any type of learning. And then being as humble as possible. So when you walk in on day one, you have learned a lot in medical school and you are very knowledgeable. You don't know everything. And so being humble and saying, I don't know, and being willing to ask for help is one of the biggest keys to success. If you don't say, I need help when you need help, that's how people get hurt. Yeah. And your learning is not improved at all by that.
And if you could say something to yourself from 10 years ago, what would you say?
Oof. So 10 years ago, I would probably have said, save more money. There were when we're younger, we don't think about what our finances are going to look like in 10, 15, 30 years. And so I probably would have told myself that, no, you didn't need to go out on this particular day or night, or you didn't need to buy that thing that you're going to forget about in 6 months or break or whatever the case might be. You don't need a new TV. And instead, put that money someplace where it can grow and work for you. The earlier you can start looking out for yourself and your own financial future, the better off you are, even now.
Well, talking about finances, do you think as a medical student or even as a pre-med or as a resident, do you get a lot of like financial guidance on like how to, like, let's say loans or how to budget?
No, you don't. The majority of those classes, at least that I received, they always happen at the end. So like at the end of medical school, you might get a class on financial wellness. Well, this would have been nice to have a couple of years ago. At the end of residency, hey, here's your class on financial wellness. Great. Awesome. Thank you. And a lot of those things don't happen unless you're seeking it out. And unless you know to ask the questions, oftentimes they're not there for you. There are great references out there. There are great sources. Everybody always cites the White Coat Investor, which is a fantastic resource. If you, as a pre-med student or a medical student, go to conferences, oftentimes there are great sessions on financial literacy for physicians that can help set you off on the right foot. But no, I don't think there are enough or nearly enough classes or educational sessions on financial literacy.
Thank you so much, Dr. Rogers, and thank you so much for the interview. I think it was amazing, and I learned a lot, and I hope everyone watching this video also is able to choose your specialty better and have a better time during their residency in medical school with your information. Thank you.
Thank you, Catherine.